Hello, and welcome to the grand rounds for the Minnesota Regional Spinal Cord Injury Model Systems, or we call it SCIMS for short. Thank you all for joining us today. So SCIMS is funded by the National Institute on Disability, Independent Living, and Rehab Research, or NIDLR. And it's funded to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide, please. SCIMS represents an exciting partnership among the following Minnesota institutions: Courage Kinney Rehab Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide, please. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical, acute care, acute rehab, and post-acute services. My name is Angie Philippus, and I'll be the moderator of today's session. I'm a project manager and a lead data collector for SCIMS at the University of Minnesota. Next slide, please. A couple housekeeping notes here. The University of Minnesota has organized the CME for today's webinar, so please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the SCIMS website. To earn CME credit for today's presentation, click on the link in the chat. And due to the number of registrants for today's webinar, we've placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the Q&A function. If you have any technical or logistical questions, we ask that you please submit those in the chat to Dan Kelly. And we want to extend a huge thanks to those who work behind the scenes to make these webinars possible. Next slide. The title of today's presentation is Hidden Battlefields, Anxiety and Spinal Cord Injury and Disorders. And the speakers for today's webinar are Drs. Jane Duff, Kimberley Monden, Lucy Grant, and Clair Pollard. Dr. Jane Duff is a consultant clinical psychologist and head of the National Spinal Injury Center in the Clinical Psychology Department at Stoke Mandeville Hospital in the UK. She has worked in spinal cord injury rehab for over 25 years, providing direct clinical therapy, research, teaching, training, and consultancy. As a member of the Spinal Cord Injury Psychology Advisory Group, Dr. Duff contributed to the National Psychological Wellbeing and Mental Health Screening Standards for people with spinal cord injury living in the UK. Dr. Duff has published widely on spinal cord injury coping and adjustment, appraisals, quality of life, rehabilitation and goal planning, and the development of self-management skills. We also have Lucy Grant here, who is an assistant psychologist who worked for the National Spinal Injury Center in the Clinical Psychology Department, also at Stoke Mandeville Hospital in the UK. She has an extensive history working with individuals with spinal cord injury, both clinically and through research. She has a particular interest in trauma and anxiety following spinal cord injury. We are also joined today with Dr. Kimberley Monden, who is an associate professor and a licensed psychologist in the Department of Rehab Medicine at the University of Minnesota Medical School, and has 12 years experience in spinal cord injury clinical care and research. She also serves as the co-project director of the SCIMS. She studies resilience and appraisals of injustice with a specific interest in improving quality of life and long-term psychosocial outcomes following spinal cord injury. Dr. Monden has research funding from NIDLR, the Department of Defense, and the Craig H. Nielsen Foundation. And finally, Dr. Clair Pollard is a consultant clinical psychologist and director of psychology and psychotherapy at South London and the Maudsley NHS Foundation Trust. Dr. Pollard's clinical work is in adult mental health, Claire is a former chair and trustee of the Backup Trust and has a spinal cord injury herself. Dr. Pollard has worked with the Backup Trust to develop a peer mentoring service for people with spinal cord injury and their families. She currently consults to the Trust on issues around mental health and spinal cord injury. So welcome all, and thank you for presenting. Next slide.
All right. Thank you, Angie, for a wonderful introduction, and it's a pleasure to be presenting today. The author or the presenters today have no disclosures that we would need to report. And as Angie mentioned, the title of our presentation today is Hidden Battlefields, Anxiety and Spinal Cord Injury. First, an outline of what we'll be talking about today. We're going to start with an overview of the literature on anxiety after spinal cord injury, which is surprisingly understudied. Next, Dr. Duff will talk about screening for anxiety during inpatient rehabilitation. Then Lucy will discuss the GAD, the Generalized Anxiety Disorder 2-item measure, as a screening measure in the spinal cord injury population. And finally, Dr. Pollard will provide a lived experience perspective of anxiety after SCI, as well as the importance of peer support. So first of all, some of you might be wondering, so why do we need to be aware of or worry about anxiety after spinal cord injury? Well, the incidence of anxiety after SCI exceeds that of the general population, with estimates ranging between 20 and 32%. And we also know that increased anxiety is associated with economic and personal burdens, including increased utilization of healthcare services and decreased productivity in the general population. And despite the high rates and negative effects of anxiety, there remains very little literature examining anxiety after SCI and its impact on functional and psychosocial outcomes. From the limited literature there is on anxiety and spinal cord injury, some studies show that longitudinally, anxiety levels remain elevated for about 2 years after spinal cord injury, while other studies report a delayed trajectory of anxiety, with initially low levels followed by a gradual increase up to 2 years post-injury. In the next few slides, I'll give a brief overview of some of these studies. So in this first study by Kennedy and Rogers, the purpose was to examine the prevalence of anxiety longitudinally. There were 104 participants in the study with traumatic spinal cord injuries, and measures were taken at 14 time points ranging from initial contact in the acute stages of rehabilitation to 2 years post-discharge. The red bars on this graph indicate time points during inpatient rehabilitation, and the green bars represent time points after discharge. In this study, anxiety was measured with the State Trait Anxiety Inventory, which has a cutoff of 48 for the anxiety scale, which will help you to interpret the graph. The data show a pattern with scores highest in the acute phase of injury and during the months leading up to discharge. You can also see a peak in anxiety at 1 year post-discharge, where the average score is 49. The purpose of this next study was to investigate the longitudinal trajectories of depression and anxiety symptoms following spinal cord injury. There were 233 participants in this study who were assessed at 4 time points within 6 weeks post-injury, 3 months, 1 year, and 2 years from the time point of injury. And analyses showed 3 unique patterns. The first was a resilient pattern of stable low symptoms, which is the solid orange line. The next is a pattern of high symptoms, followed by improvement, which is the dotted green line. And finally, the last line is a delayed trajectory of anxiety, with initially low levels of anxiety followed by a gradual increase up to 2 years post-injury, and that's the dotted orange line. And in this final study I'm going to review today, the purpose was again to investigate the longitudinal trajectories of depression and anxiety following SCI. In this study, participants were assessed at 5 time points: admission to rehab, discharge, 3, 6, and 12 months post-discharge. And this analysis showed 4 trajectories. For most people, the trajectory of their anxiety was stable over 1 year. These are the gray lines. However, for a small group of individuals with very high anxiety, represented by the black line, their anxiety increased over time with a further increase at 12 months post-discharge. So now that we're all convinced that anxiety is something we should worry about, I hope you're all getting the pun. I'll turn it over to Dr. Duff to discuss the importance of screening for anxiety.
Thank you very much, Kim. Hello, everybody. So yes, that's the purpose of the next section that I have got. And I'd also just like to acknowledge, in terms of my organisation, that today is the 80th anniversary of the National Spinal Injury Centre. So it's our Founders' Day today. And it's a wonderful day to be talking internationally and continuing the Gutman, Papa Gutman legacy today. Next slide, please. Thank you, Angie. So Kim's giving an overview of how important it is to consider anxiety. And just to broaden that, that theme, we're thinking about there may be people who have pre-anxiety to their spinal cord injury, which is an important group of people to consider about, and the vulnerability from previous experiences. And then there are also a group of people who may not have experienced any anxiety in their life prior to their spinal cord injury, but the spinal cord injury itself is particularly challenging time. There's a lot of unpredictability and uncertainty, particularly in relation to bladder and bowel function. There's ongoing pain, there's concerns and confidence issues in terms of whether people can transfer and learn to transfer. There's a lot of learning to trust and read your body again, and learning to read the signs of a changed body. And also those aspects might trigger some fundamental beliefs and assumptions that people have that they've learned over time in terms of who they are as a self, their sense of competence, their sense of purpose and identity, and their role in the world. And the spinal cord injury can really challenge a sense that the world is a safe place and a sense in the benevolence of others. So it's a unfortunately ripe moment of time of threat and challenge for people after a spinal cord injury. Next slide, please. So in thinking about this from an appraisals model, Folkman and Lazarus developed a model in the kind of late 80s, 90s. Professor Paul Kennedy and I interpreted this model for spinal cord injury, and we identified particular pre-injury factors and where it is about those beliefs about self, world, coping schema, and particularly with the spinal cord injury, any pre-existing beliefs about disability that may be activated when somebody has a spinal cord injury. The circle in the middle, the appraisals process, is similar to the Folkman and Lazarus one, but Paul Kennedy and I considered in spinal cord injury, there's two potential belief sets that can influence how people cope. A belief about a spinal cord injury is manageable, which we hypothesized would lead to approach-focused coping and kind of a range of outcomes. And then a path of believing about spinal cord injury is unmanageable, and the risk that this might lead to avoidance-focused coping and the potential impact in terms of mood and helplessness and hopelessness. And in terms of Folkman and Lazarus' model and our model, because the stress and the coping isn't resolved, that's a reboot. It kicks a reboot back into the reappraisal cycle. And if that goes on for a long time and consistently, it can lead to the secondary complications of self-neglect and stress. Next slide, please. So a simplified version of this is really identifying a manageability, approach-focused adjustment pathway, and a pathway of unmanageability and avoidance coping. And it's that avoidance coping and anxiety that can be really key in the maintenance of initial symptoms and feelings of anxiety for it actually to become ingrained and a disorder. Next slide, please. So this is an example from a gentleman that I worked with. He had some pre-existing concerns about hospitalization, but not any contact with mental health services and not any contact with psychology and therapy prior to his injury. But he was very fearful when he was learning to get dressed in physio and OT. And there was a cycle, that kind of cognitive behavior cycle, that went on, in that he would start to wobble during dressing practice with the OT, physical feelings of hot and panicky and blurry, feeling overwhelmed and tearful, and then the thought that life is over and I've always been very fit and in control. What he physically did, and the reason why the blue box is so important, is that was what he and the physio and the OT were experiencing in the room. And so he would lift his feet and lean back and become more unstable, which would increase his anxiety, increase his thoughts that he's going to fall, and round it went in the therapy room. But what wasn't anticipated or experienced so much was the psychological core beliefs that went on for this gentleman, which is where I came in to work with the team. And the real danger for him was that cycle going round in physio and OT was actually leading to a more core and ingrained cycle of his core beliefs about this is stupid, I'm stupid, I can't do this. And then much more negative beliefs about himself. If I can't do this, I can't do anything. And what he felt was, I've got no interest in living as a cripple. And that's the real danger moment for someone, as they're beginning to experience anxiety in a rehabilitation setting, that it can have a much more longer term impact. Next slide, please. So anxiety and worry is a normal response to spinal cord injury, and it's really important to normalise those emotions. But it has the potential to become a barrier, either currently or in the future. And the really tricky thing about working with anxiety is that, in terms of diagnostic criteria, it is persistent for 6 months or more, which is often beyond when people are in rehabilitation. So that's why it's important to screen. And Kim and myself worked on the ISCOS basic psychology dataset, which recommends the PHQ-2 and then 9, an advanced measure, and then the GAD-2 and the GAD-7. And it was part of our work on that data set that led us to be involved in this paper and sharing the fact that we had GAD-2 and GAD-7 data. Next slide, please. So Lucy's going to be talking a bit more about the paper that came from that. And it was the first time that data using the GAD-2 and people with spinal cord injury had been compared and cut-offs had been examined. Thank you. Next slide, please. So this is what the GAD-2 looks like. Probably many people are familiar with it. It's a brief screen of just 2 questions. And in primary care, it recommends that a full GAD-7 screen is completed if people score 3 or more. And for the GAD-7 itself, it's recommended that a mental health clinician-led interview if someone scores 8 or more. So Lucy's going to talk a bit more about the actual cut-offs and applying those in spinal cord injury. But a real caution is that the GAD-2 is a screen, and it's a screen to identify the need for a mental health-led clinician interview. But considerations for people with spinal cord injury, and this is why a mental health-led clinician interview is really important, is the anxiety response temporary as part of rehabilitation? Is it a risk of a longer lasting and social participation limitation? Or is it another anxiety disorder or adjustment disorder or a specific phobia or a fear of falling? So there's many considerations that need to be unpicked just when somebody screens in relation to the GAD-2 or 7. Thank you. Next slide, please. There are many, many places that don't have access to a mental health clinician or a psychologist. Bombardier, Jack Bombardier, in his the PVA guidelines, has given some really helpful strategies if that is the case, and the things that MDT members can do if they do that screening and notice somebody having significant problems with anxiety, things that can actually help somebody in the moment. And many of these would have been relevant for the gentleman that I mentioned. So there's a heightened need for consistency and control. There's probably a more heavy reliance on staff for reassurance. Now that can go both ways in anxiety, because that can become a kind of safety-seeking behaviour in itself. But that's not to diminish the fact that actually when somebody's asking for reassurance, and whether they are, if for example in the gentleman's case, the falling back, that needs a lot of reassurance in terms of his stability and ensuring his feet are planted firmly on the floor. Potential anger. There's a lot of need for enhanced information and predictability and routine, which enhances someone's feelings of control. There might be increased need for feedback about process or concrete or smaller goals. A fear ladder can help so that the multidisciplinary teams start at the easiest point and the least challenging point for someone, and then increase up the ladder as people's confidence increases. Graded exposure is similar to that. And also, I would very much encourage that when people are experiencing high levels of anxiety in a therapy situation, that they stay in that situation, because often people remove themselves from that situation at that moment, which in turn develops this cycle of anxiety and avoidance. And naturally, levels of anxiety reduce over time if it stayed within the moment, and that's a really important learning in itself. And there can be other things that can help in terms of errorless learning, community visits before discharge, and any additional support for transition and periods for change. Next slide, please. So I'm going to hand over to Lucy, and thank you very much for your interest.
So hello everyone, so my name is Lucy. I'm an assistant psychologist, and as Jane mentioned, I'm going to be talking to you today a little bit more about our findings on GAD cutoff score to identify anxiety symptoms, which until our research hadn't been studied before for individuals with spinal cord injury. And next slide, please. So firstly, a brief overview of the samples that we included in our study. So we had a large sample size of 909 participants in total, comprised of 3 different samples. So 1 inpatient sample in the UK and 2 community samples based in the United States. So I suppose one of the key things that we were looking for is just to see whether any differences existed between samples in relation to anxiety, the occurrence of anxiety symptoms across samples, and or whether any differences existed in cut-off recommendations across samples, just taking into consideration potential contextual and cultural differences, with this being UK and US, as well as inpatient and community participants. So I suppose it makes sense for us to kind of point you in the direction of our full research paper. The link you can see there, as well as the accompanying podcast, which is free to listen to. So hopefully you'll be interested in finding a bit more about our study and some more detail into it as well. And next slide, please. So firstly, to examine our data and see whether any differences did exist, we were looking at, firstly, at the demographic data. So for our continuous data, we used a one-way analysis of variance, or an ANOVA. I won't go into the specifics of the statistics or the mathematics behind that, but effectively it's comparing means between samples for the brief GAD2 measure as well as the full GAD7 measure. So importantly, we didn't find any significant differences in mean total score for either measure across the samples, which effectively means that the average score across samples for different participants was quite consistent, which can add a bit of confidence into our results. The Craig Hospital sample was slightly younger in age, which was just something for us to bear in mind when kind of doing the full analysis later on. The UK sample was slightly older in age at injury and had a fewer time since injury, the latter of which was expected, again, because it is an inpatient sample, which typically means that get my words mixed up, which typically means that individuals are reach a spinal injury inpatient unit for rehab a couple of months kind of after injury. As well as this, the anxiety severity classifications, or how severe anxiety symptoms were, was also very consistent across samples and for the combined sample as well. So again, adding some confidence in our results. And next slide, please. So in terms of anxiety occurrence, we were looking at the frequency and percentages at each cutoff score for the GAD2 measure. So as you can see here, there was quite a kind of similar percentage across samples and in the combined sample, and kind of importantly, most similar, not too much of a drop off compared to a cutoff of 1 or above on the GAD2 and 2 or above on the GAD2, fairly consistent between those. But we do see quite a large drop off when going from 2 or above to 3 or above on the GAD2. So really what that means is the higher the cutoff score that we have on the GAD2, the more people with anxiety symptoms will be missed, which means that potentially we're missing people who could go on, who maybe already have anxiety or could go on to develop anxiety and have kind of clinically relevant symptoms for both the full measure and then the diagnostic interview if they reach threshold in the full measure as well. Next slide, please. So in terms of kind of the meat of our data, if you like, so we were using, to identify the best cutoff score in the GAD2, we were examining this more closely by using what's called a receiver operating characteristic or a ROC curve analysis. And effectively, this is a measure of sensitivity and specificity. So what do I mean by that? So sensitivity is how correctly identifying individuals with anxiety symptoms, and specificity is correctly identifying individuals without anxiety symptoms. So crucially, the more you have of one, the less you'll have of the other. And so really it comes down to kind of clinical judgment as to which is optimal in finding that balance between both specificity and sensitivity. In terms of the graphs there, what we were looking for is to kind of add confidence to the sensitivity and specificity calculations. We're looking for the blue line there, the kind of curved line, to be as close to the top left-hand corner as possible. So as we can see, that looks really good from the graphs as a visual representation. And also we can see that there's consistency again between samples. And from a kind of numeric summary of this, that is defined by the area under the curve, or the AUC. And typically anything above 0.9 is considered excellent, which all of ours were. So again, very good for us. Thank you. Next slide, please. So then looking at the sensitivity and specificity output. So for this, again, as you can see, for GAD2 measure, a cutoff of 2 or above and 3 or above, actually both of those were providing really good sensitivity and specificity. And for this test here, we were looking, anxiety was counted if individuals scored 8 or above on the GAD7, so the full measure. And then the ROC curve analysis would then break that down based on the cutoff scores on the GAD2. So crucially, again, with this is that we wanted to prioritize sensitivity. So in other words, we wanted to capture most individuals with showing anxiety symptoms and just being a bit more kind of cautious, because obviously, as you can probably tell from our presentation so far, we think that detection of anxiety is really important. And so we thought that sensitivity should be prioritized over specificity in this case for this population as well. Thank you. Next slide, please. So really kind of to summarize all of this, we've hopefully made clear what kind of recommendations we have when using the GAD2 for people with spinal cord injury. And that is really just the more conservative cutoff of 2 or above. So crucially, the higher the cutoff score that you use, regardless of whether it's the GAD2 brief measure or the GAD7 full measure, the higher the threshold that you choose, the more people with anxiety symptoms will be missed. So by being more conservative with that, going for a lower score of 2 and above on the brief measure and 8 or above on the full measure, then it means you'll be capturing more people who otherwise might go unnoticed and not get the support that they need. And 19.4% of those scored kind of on both of those thresholds for the GAD2 and the GAD7. So a significant proportion of people with, potentially needing support for anxiety symptoms. And when you think of the kind of knock-on effect that may have as well, so we know from other research that poorer psychological health results in poorer rehabilitation outcome. So really showing the kind of the relationship there between psychological health and physical health. And the fact that anxiety is under-recognised anyway means that lower cutoff scores for the GAD measures, both of them, is really important, again, in order to kind of capture those people who otherwise would go unnoticed. So thank you. I will now hand over to Dr. Clair Pollard.
Thank you, Lucy, and hello, everybody. I'm coming today wearing two hats, which always feels slightly uncomfortable, but I am both a consultant clinical psychologist and also have lived experience of spinal cord injury. Next slide, please. So I thought it would be helpful to perhaps just tell you a little bit about myself in these two roles. So I was injured in a road traffic accident in 1999 whilst travelling with some friends in Namibia, and was actually 6 months into my training as a clinical psychologist at that time. I have a T8 complete injury, and always find this online forum slightly difficult because it takes away some of my identity as a wheelchair user and someone living with that disability. Following my injury, I was fortunate enough to do 5 months of rehabilitation at the National Spinal Injuries Centre at Stoke Mandeville, which is where I first met Jane. And following my injury, I then returned to my training and later returned to Stoke Mandeville to complete my doctoral research with Paul Kennedy in Jane's department at that time. Following my qualification, I specialised in adult mental health and have worked in that area for the whole of my career, which is 25 years just coming up to in the NHS. But in my spare time, I also work with a National Spinal Injuries Centre in the UK called the Backup Trust, which, next slide, please. So just to tell you a little bit about Backup. Backup provide rehabilitation services for anyone affected by spinal cord injury. So that really does mean anyone affected. So it's both the person with the injury themselves, but it's also their family and significant other people in their network. All of Backup services are peer-led. So everything that Backup does is delivered by either people with a spinal injury themselves or with people whose loved ones have a spinal injury. And the project that I'm particularly involved with is that about 16, 17 years ago, we set up a project training people with spinal cord injury and family members to mentor people in the first stages of recovery from injury. The training is run by clinical psychologists, so there are 3 of us that deliver the training, and it involves a weekend's residential course, training the peer mentors in listening skills, in problem solving, risk management, and various ways of using their own experience really effectively. And unusually, I think, for sort of peer mentoring services, we have quite a strong matching process that people go through when they apply to have a mentor. So we match people on level of injury, on age, gender, other things that feel relevant to make sure that the right support is given, because, of course, people's experience of spinal cord injury is very different dependent on some of those factors. The reason that we wanted to talk about this work today is that all of the services delivered by the charity are based on the psychological model of adjustment put forward by Duff and Kennedy. So the services very much focus on that appraisal that people make of their injury as being either manageable or unmanageable. And what we find is that peer support can play a massive role in that appraisal. If people are able to experience someone that they can see managing their injury, then they're much more likely to appraise their own situation in that way. And what we do find is that anxiety is a huge feature of the presentations that come to Backup. So lots of the things that Jane mentioned previously, but fear of negative social evaluation, bladder and bowel problems, fear of the future, of further injury or illness, and lots of negative self-perceptions. And what we do in all of backup services, but particularly in mentoring, is we try and target things that we know maintain anxiety, such as behavioural avoidance, negative appraisals, and cognitions that might be maintaining the anxiety. Next slide, please. I wanted to just very briefly give you an overview of the types of outcomes that come out of this, because as a clinician working in the NHS, I'm actually sometimes quite envious of the types of outcomes that backup achieve in their services. So, for example, in 22-23, we had 87% showing an improvement in 3 or more measures, outcome measures. 86% of people report having achieved their personal goal. And with wheelchair skills training, which is another peer-led service that backup offer, we had 99% of people reporting that they felt more confident and 98% saying that their spinal cord injury felt more manageable after the sessions. And the feedback that we got was, I particularly like this quote, which was, "My mentor was amazing. She gave me a lot of hope and was so easy to talk to. Just knowing that she had been on the journey and could help answer so many questions was so very much appreciated. I felt alone, but since making contact with backup and now the mentoring service, I feel this will not be the case." And I think that really for me gives the feeling of why peer support is so important in tackling anxiety following spinal cord injury. Next slide, please. So I'm going to give an example. I thought it would bring it to life a bit to talk about an example. And you'll see that I've written this from quite a clinical perspective, because I guess that's how I think as a clinical psychologist. But I also think that it's quite important for me to disclose that this is actually something that happened to me in my own life. It's not an easy thing for a clinical psychologist to talk about a mental health issue in their own life, but I actually think it's really important in terms of breaking down the stigma that can attach to these things and showing that this really can happen to anyone, even someone who's very well trained and versed in CBT. This was a difficulty that developed when I'd been injured for about 6 years, so a very long time ago now. But the trigger for this was developing a small pressure mark, which necessitated 2 weeks bed rest, and was, a frightening experience because of the thoughts of what could happen or what might happen as a result of that. The symptoms that then developed were very high anxiety, panic attacks, preoccupation, frequent and very distressive, intrusive images of pressure sores, skin breaking down, sorts of things that can happen, and really a sort of felt sense that something bad was happening. Irritability, poor concentration, lots of fear about the future and what might happen. So the feeling that it was almost inevitable that at some point a really catastrophic pressure sore would happen and would be very life limiting. And obviously consequent impacts on family relationships and occupational functioning. The maintenance factors, and this is very much from a CBT perspective, were really checking skin up to 15 times a day, needing to go back to bed to check skin, avoiding anything that might be risky, so long car journeys, sitting on the sofa, transferring out of the chair, lots of things around that, reassurance seeking, and lots of sort of seeking out confirmatory information online, and really sort of honing in on stories of pressure sores, people who'd been in bed rest for years with pressure sores, and thinking a lot about that. Next slide, please. So just thinking about how we might help someone recover from this. And what I thought was really interesting for me about this, when I was able to think objectively about this, is that a lot of the things that were maintaining and driving the anxiety were things that actually we learn in rehab. So of course we learn to check, we learn to avoid risky situations, we learn to ask people advice. And those things, of course, in moderation are absolutely right and are what we should be doing after a spinal cord injury. And yet for me, they also became a problem and fed into the anxiety cycle. So the things that needed to change were really reducing checking behaviour. So really being sensible about that. It's not sensible to not check. You need to check when you have a spinal cord injury and paralysis. But there are sensible things around that. So seeking advice, thinking about what's a sensible amount. So it was checking once a day, making sure that, I wasn't overly doing that. reducing reassurance seeking, particularly around getting my husband to not give reassurance. Very hard for him, very hard for partners to do that. And then reducing avoidance, so using behavioural experiments to try out things that previously wouldn't have been a problem and actually weren't as risky as they felt. So car journeys, sitting on the sofa, transferring in a theatre into another chair, those sorts of things. Managing the catastrophic thinking and intrusive imagery, using lots of ways of remembering that just because it feels that something is wrong doesn't mean that there is something wrong. Not Googling. Dr. Google is not your friend when it comes to anxiety, and giving information to family. And now I'm pleased to say that many years later, I check my skin once a day and do not avoid things anymore. I think there is always some nervousness about skin, but perhaps that's adaptive, and it's certainly within manageable levels. So thank you.
Wonderful. Thank you all for a really excellent presentation. We now invite folks to type in any questions or questions in the Q&A box. I know there was a good question that I think Lucy was able to address, and that had to do with, was there any differences in anxiety reported across countries? And Lucy, correct me if I'm wrong, but I think you mentioned that there were no differences found on the GAD between countries. Is that right?
Yeah, that's right. So the fact that this was kind of the first time that this was examined with people with spinal cord injury as well, we weren't sure if that would be the case. We were almost kind of expecting some form of difference, not only because, as has been pointed out, it was 2 different countries, but again, also just the quite vastly different nature of kind of inpatient compared to community in terms of, time since injury and things like that. I think sometimes there can be an assumption that anxiety might be higher soon after injury, in which case maybe the inpatient sample would have had higher rates of anxiety occurrence. But, as has been pointed out by Kim and Jane earlier in the presentation, prior research has suggested that there are different trajectories of anxiety. So the fact that in such a large sample as ours and across, quite different demographics, that the rates of anxiety were quite consistent across samples was surprising, but I suppose good for us as researchers to then be able to have quite a consistent message in terms of the cutoff score that we recommend.
And our sample from the University of Minnesota was actually data pulled from another study that was conducted online during the pandemic. And I think you see that our scores are a little bit higher than the others, although there wasn't a significant difference. But that actually was a sample of people across the United States, not just in Minnesota or the Minneapolis area.
Great. Any other questions from the attendees today? Or any comments, any additional information that our presenters might want to add?
I guess, if I may, just to highlight the importance of screening, from Claire's description of her experience as well, that it's something that asking those couple of questions on the GAD can highlight the need for a deeper conversation, which is where Kim and I connected with, in terms of the ISCOS psychology data set, of how to begin to recognise those symptoms of anxiety after a spinal cord injury. And certainly the people that I see who are 2, 3, 4, 5 years after spinal cord injury, when those early symptoms aren't picked up, and certainly when people transition into the community, the participation element can, your anxiety can have a real impact, or your fear of having a bladder or a bowel accident can really limit participation. And then it becomes a whole cycle in itself that you don't begin to build up those transitions, which is where backup and peer mentoring and peer support can really help.
Looks like we have a quiet audience, or you guys just really touched on everything quite well. I don't see any more questions.
If there's any clinicians on, now's your chance to access 3 psychologists. If you have any questions about, anxiety you see during therapy sessions and maybe how to approach that. We'll just give it a few minutes, and if there's no questions, then we will part.
Oh, I see something coming through. A question here says, do any of the researchers feel it would be beneficial to give some form of anxiety education inpatient as a standard and not just when a problem is noticed?
So, Jane, you may do something different, Claire, you as well, but I do a lot of psychoeducation, especially on inpatient rehabilitation. A lot of times we're called in and people haven't really asked for a psych consult, and so they're a little surprised when a psychologist shows up in their room. And one of the ways I bridge that gap and build the relationship is through psychoeducation. And I will go through, a lot of times after spinal cord injury, people may experience X, Y, Z, and go through some of those things to see maybe what they sort of endorse or where they kind of perk up. And then I know that's sort of my window to get in there. But I do believe the psychoeducation piece is very important because we know there's that delayed trajectory too, right? And so I think when I do my last session with people before they transition back into the community, not to be all doomsday, but I talk about difficulties in transitioning and things that may come up down the road, and anxiety is one of those things.
And similarly, I would do the similar to Kim in terms of when I meet with people on an individual basis, and also in that kind of final session, preparing people to move from a very structured environment, which tends to be timetabled in rehabilitation, and how you're going to manage that transition and the kind of goals and structure that you want to move into in the first week, couple of weeks, month after discharge. But the other thing that we do is a psychoeducation group, in which there's it's longer rehabilitation stays in the UK. So about a month after admission to our rehabilitation centre, there's a number of group psychoed sessions, and there's one on resilience and coping with spinal cord injury. There's one on my health, and there's one on pain. And talking about anxiety, very much normalising, what are some of the difficulties that can be experienced. And how they can, what you can do about them at different points in time if you do experience them. And I think more information that people know about the possibility of that, it gives people tools that they can then use in the moment as well. Claire, what do you think?
Yeah, again, I would completely agree. And I think that normalizing is really, really vital. I think actually normalizing to the extent of saying to people, everyone will feel anxious at some point. This is a new world that you're entering that can be very, very challenging. And I think sometimes people's experiences that we hear about is that rehabilitation can be very focused on the positive and what's possible, and doesn't always bring people back to, but it's really hard, and it's going to be, and yes, it's possible to have a really valuable life following a spinal cord injury, but it's also going to be tough to get there, and there are going to be times when it's hard. And so I think really equipping people to know that, and I think crucially what you said, Jane, about where to go for help. I mean, the example that I gave, my saving grace is I'm a CBT therapist, right? I understood reasonably quickly what was going on. If you don't have that, if you don't know to do that for yourself, then how do you know what's happening for yourself? And I think possibly when we're thinking about that kind of teaching you know, the intrusive images that I experienced were pictures that I was shown in my rehabilitation of what a pressure sore looks like. You know, so I think there's something about when we're doing that, it's really important to equip people to keep themselves safe and well, but maybe we need to support that with thinking about what that may trigger as well, and what that may bring up to people, and how to manage that, and how to tell when it's time to get help or when it's time to reach out, I think is crucial.
It looks like we have a couple more questions for you. First one is, I am a social worker at outpatient rehab on the spinal cord injury team, and noticed that most of our patients decline mental health treatment initially, but sometimes agree months later. So I do check-ins monthly with patients to monitor. Any other tips for engaging patients and accepting help in this way?
That's a
I would say,
great question. Oh,
yeah, great question. I would there is a stigma around mental health, and so I think actually talking about more ordinary things that somebody's going to need to think about after a spinal cord injury, like return to work, or like their partnership role, or their parental role, or their role as a carer, or those kind of things, and saying, where are you with that at now? Do you have any concerns? Is there things that you're kind of worried about? Is there things your partner's struggling with? So to really look at different inroads of just normalizing, this is something that has turned your life upside down, is catastrophic in your life, and people aren't equipped to manage with a situation like that. It is normal to feel challenged, and I often talk about it being, you know, it's an extraordinary situation, and that your ordinary approach might be really, really challenged. Just try and normalize that approach, and just to check in about ordinary everyday things in life, to destigmatize the mental health. Is there something extra wrong with me in terms of my mental health now?
agreed. And then I think the other important point is a lot of people have, you know, this preconceived notion of what a psychologist is, and delving into their childhood, and it's this kind of long road and very scary. And what we do in rehabilitation psychology is very different. I mean, unless childhood trauma comes up, I'm not really going to dig for it. So it's a little more kind of based in the present, the way I practice. And so I think demystifying that, because I think people are already in a vulnerable place, and it's sort of like, well, I can't be vulnerable physically and emotionally at the same time, and it's just too much. So that's one way I go about it too. When I introduce myself and they're a little, it's like, okay, you know, I'm here to provide support and education, and you know, I'm not here to push you into any zone that's really uncomfortable. So demystifying my role as a psychologist in rehab.
I think, again, that's where peer support, I know I keep saying this, but can really help, because I think if people talk about in this way, in the way that hopefully I have done today, that, you know, you talk about this being part of what's happened, and a very normal response, but also something that can be helped, and something that you know, there are clear good treatments, there are things that can help, there are things that can make a difference, and I think the more we get people to be honest and upfront and talk about that, again, it's affecting people's appraisals of their situation, thinking about, actually, I feel this way, but this can be managed. There are ways to do this differently. So yeah, I think there's something about openness around that, and encouraging that.
Great. I think this we have time for one last question. I believe Lucy, you touched on this a bit. So maybe you can help us out, Lucy. Have you run across significant differences in the prevalence of anxiety based on a person's age or stage of life at the time of injury?
Yeah, so there weren't any kind of significant differences related to age and kind of anxiety symptoms or score. So the only thing really that was found was just a slight difference in age kind of between the Craig Hospital sample compared to the other ones. But yeah, Yeah, not in our study. I'm trying now to think through kind of previous research in case there have been anything to do with that. Yeah, Jane, I think I'm having like a mental block here as to whether
I'll
it was.
help you out. I think one of the so this probably points to one of the needs in relation to anxiety and its under recognition, is that it hasn't been researched longitudinally or cross-sectionally as people age with injury. And I mean, I know Paul and Claire followed up with Paul's sample that Kim presented initially. Paul and Claire followed them up at 10 years, I think, Claire, and then again, Paul followed them up at 21 years in 2016. And there were relationships between the coping strategies people used initially at that 12-week point after spinal cord injury, both in terms of anxiety and depression, and their coping in the long term. But people haven't been followed up consistently over time or at different time points as they age. So that would be important to do, because we know from longitudinal from research in terms of lifespan, is that the aging process can start 10, 15 years earlier with spinal cord injury, and so that might bring itself an increase in symptoms of anxiety. I don't know, but it would be kind of useful to know that in terms of people's needs. Claire, you look.
I was going to say, certainly anecdotally through backup, and we don't have the evidence for this particularly, but I think there is. So what we've seen, as many have over the years, is that over the last few years is that the demographic coming to backup has changed significantly. So when I was first involved, when I was first injured, lots and lots of young men, young male paraplegics, and now we have a far greater age range. And there's often an increase in anxiety in those people who are injured later because of and the fear of falling, the fear of, I think there's something about a sort of it's more difficult to be flexible. People are more fixed in their lives and in their beliefs and in the way they do things. And then a catastrophic change like a spinal injury, I think, can have a greater impact in that situation. And I think but as you say, Jane, I think the other thing that we see is an increased anxiety as people get older with spinal injury, because, you know, things like just their physical condition becomes more challenging. I mean, that's true for everyone, right? As we get older, our physical condition becomes more difficult. But with spinal injury, I think there's a particular issue with that. So, yeah.
Wonderful. Thank you, presenters, and also thank you all for attending today's Grand Rounds. If your question didn't get answered, or if you think of a question later, feel free to reach out to the presenters directly if you'd like any kind of follow-up, or if you want to talk more. The recording for this webinar will be posted soon on the SCIMS website with a link to our YouTube channel. And as a reminder, see the chat for information on how to obtain CME credit for attending today's webinar. And then at the end of the webinar, you'll see a brief 3-question survey that will pop up. We'd really appreciate your feedback. We hope you can join us for our next Grand Rounds, which will be on Thursday, April 6th. And that's going to be at noon Central Time, where Dr. Michael Stillman and Dr. Nethra Ancom will present one institution's efforts to address disability-specific medical education. So thank you all and have a wonderful day.